Good day, everybody, and welcome to Los Angeles. My name is Stefano Conti. I'm from Parma, Italy, where I actually have my private practice. Today, we will talk about full mouth rehabilitations with hybrid prosthesis and the role of prosthetic artificial gingiva in the aesthetic implant dentistry. Let's see together the classic indications for implant therapy. In the 80s, we used to call our implant therapy a functional-driven therapy. In the 90s, we used to call the implant therapy a prosthetic-driven therapy. Our goal was to provide our patient with health and function. So we place the implant in the position where we have the bone and give our patient health and function. We can call this approach a bone-driven approach in our implant therapy. Then in the early 2000s, we evolved to a new concept of implant therapy with a biological-driven therapy where the clinician first established the ideal position of the restoration, optimizing the function and the aesthetics, and then place the implant. Of course, this approach requires a side development, requires the possibility to give our patient surgical procedures to augment bone and soft tissue. We can call this approach a restoration-driven approach. And often, when we have bone and soft tissue surgical procedure in a class 3, which is a horizontal and vertical defect, we are not sure to provide our patient a natural aesthetic result, or at least it's very difficult. Let me give you an example. This patient with 4 missing teeth in the frontal aesthetic area, we placed 4 implants. We did surgical procedures with the GBR augmentation of the bone, and we actually used new materials, aesthetic materials like zirconia abutments, and new technology like a CAD/CAM technology. But at the end, the final prosthetic solution from an aesthetic point of view is not acceptable. As you can see, we have a missing papilla here, and the architecture of the gingival margin is not ideal. We're missing something. We have a functional and aesthetic dilemmas. Often when we approach to surgical procedures, we get a lot of bone and soft tissue augmentation, but still when we have to proceed with our prosthetic approach, we have to deal with narrower and longer teeth. We have an inverted smile line. Often we have rectangular teeth because we don't have the papilla, so we have to extend our contact points more apically. We have the inversion of the tooth axis and, in complicated cases, unsupported upper lip. Above all, we often find ourselves with an unsatisfactory papilla and gingival aesthetics. The question is, are we able, whenever we provide our patient with surgical procedures for augmentation of bone and soft tissue, are we able to give our patient a predictable aesthetics? Let me show you one case, a complicated situation where we have a horizontal and vertical bone defect. In this case, we will see together that I've been approaching my patient with a different treatment option. We have an important defect, and the treatment option is a gingiva-colored pink restorative materials. With the gingiva-colored pink restorative materials, we can overcome the limitations of grafting and should be a consideration in the initial treatment plan. And then, after that, we have a complete control of the free gingival margin we have a complete control of the teeth anatomy, and it's going to be a very easy procedure instead of a surgical procedure. And with the CAD/CAM technology, we can have a copy of the provisional and create a framework. Like in this case, we have a zirconia framework, and after that, we can add ceramic on the buccal aspect of our framework and get this way to the final restoration. We get from here, with the CAD/CAM technology, with the zirconia framework, to here. With the help of gingiva-colored pink restorative materials. And as you can see, it's a quite easy procedure. And from here, where we have a vertical and horizontal defect, we get to the final restoration, where we have again the complete control of the aesthetics. And in the same time, the flat shape of the ridge is a cleansable surface and produces an aesthetic horizontal interface between natural and artificial gingiva. So we can maintain in the time the hygiene of the patient. Let me introduce you now the proposed implant prosthetic design, depending on the atrophy of the maxilla or mandibula in edentulous patients. We can actually classify 3 different classes. Class 1, with absence of significant atrophy. Class 2, with a moderate vertical and or horizontal atrophy. Class 3, with advanced atrophy, and in this case we need a pre-implant surgery. Let's see the classes one by one now. In the class 1, the anatomical situation can be considered adequate for the realization of a fixed rehabilitation. We have an absence of a significant atrophy, and the treatment options are available. I mean, all the treatment options are available. We can pass through an overdenture to an hybrid prosthesis to a fixed rehabilitation. Most of the time depends on the patient's expectations and the cost of the treatment. Let me show you one case example. A patient with a edentulous maxilla, with an optimal gingival architecture, with a normal interarch relationship, with a wide ridge and thick mucosa. It's a beautiful case because we can actually provide our patient with a traditional prosthetic, recreating the natural gingival architecture, utilizing his natural pink soft tissue. We place the implant with a surgical guide in the right position, mesiodistal position. We've been using implants gIDE dense ply, 3.8, 4.5 millimeters diameter, and with an immediate load procedure. And as you can see, the shape, the concavity in the frontal area after the immediate load with the provisional is quite nice. We get to the final prosthesis utilizing titanium abutments. As you can see, the tie-in of the framework is quite precise. And let me spend you a few words about the aesthetic area, the frontal aesthetic area. In this case, even if we have a beautiful maxilla with a wide ridge and a thick mucosa, I prefer not to place implants, and I prefer to get to a ovate pontic side development to recreate the natural gingival architecture. With a round bar, I can create a concavity, and then with a provisional, I can push up the mucosa until I get to the final natural architecture. With this procedure, I can get to a natural aesthetics in a quite easy way, because we don't have implants. And we know for sure that, as you can see in the picture, we can get up to 6 millimeters of height of a mucosa, which is not possible whenever we have implants. What we have learned today is that the use of an hybrid prosthesis with a prosthetic gingiva gives us the possibility to control the aesthetic in a way that we've never been able to do before. Instead of an invasive surgical procedure to augment bone and soft tissue with the intent to recreate the natural gingival architecture, we have now a different treatment option that gives us the complete control over gingival architecture and teeth anatomy. We also learn that the hygiene should not be a problem if the restoration is designed properly, and that the pink prosthetic gingiva should not be used only when we are in trouble, but we should use it as a treatment modality, because we are able to provide our patient with excellent and predictable aesthetic results for a long-term success. Thanks for joining me, and hope to see you again.
For more education programs, visit the GIDE Institute at www.guidedental.com.